Is now starting. All attendees are in listen-only mode.
All right, I think we're on the air here, Rich. How you doing?
Doing well. Thank you, sir, for asking. Hope you enjoyed your week off last week for spring break.
We did. I don't know that the rest of the world knows here in west coast of Florida that spring break's over, for me anyway, because the traffic is just horrendous. The weather's been good. But yeah, we had a great week. Thanks for asking. Everyone, tonight we're going to talk about dental sleep treatment steps, and how we're going to do these efficiently and properly. So dental sleep is basically just one step after the other. Nothing is that complicated when you look at it individually, but as we string these steps together, a lot of offices get confused and they get bogged down and take more time than really is necessary. We have quite a few people on here tonight. We will get to your questions. We've got everybody muted because we had several hundred people register today. So just let me know and type your questions in the questions box and we'll get to them. And we do these about every other week. And, here's why we do this. I think some of you are new to dental sleep, maybe that are attending tonight. And I think most dentists screen for oral cancer. I mean, Rich and I have been out of dental school a long time, each of us. So I guess pushing 30 years each here, so.
Who's counting anymore, guy?
Yeah, no kidding. But, they taught us to screen for oral cancer. And I think it's important because it's in our wheelhouse and we've got to be looking at the tongue and the structures. But, when we do lectures, Rich and I, which we do all over the country, which we'll talk about in a little while, I always ask at the beginning, how many of y'all screen for oral cancer? How many did you find? How many of you found more than one last year? More than two? More than three? And the hands keep dropping. Most I've seen is 6, and asking that to thousands and thousands of dentists in 1 year. And still that's substantial and it's concerning. But if you start screening your patients for obstructive sleep apnea, 1 in 5 adults, by most standards, maybe even pushing 1 in 4 adults has obstructive sleep apnea, and it's in our wheelhouse. It's something we should be doing. The ADA now actually recommends that we, as dentists, should be screening for this. So not just 6 a year, you can find 6 in a day in most dental offices, or 1 a day at least. If you have 6 patients, I guess you could, or 5 patients, you should say. So it's something you all should be doing.
Yeah, we hope it's on your radar. It apparently is, because you're here tonight, spending part of your evening with us. We thank you for doing that. And, like Guy mentioned, the ADA, the American Dental Association has actually put out a position paper on that now, where they're looking at, should we as dentists be doing this? And we really should. So we don't want to scare you off. We see a lot of new names on these webinars. Like Guy said, we get to do an awful lot of this. And we love seeing new names on there, because that's why Guy and I started this several years ago. It's just hard for dentists. They don't know where to go. They don't know how to get answers. So think about this, Guy. I think a good way to look at this tonight is kind of, from the 10,000-foot view. If you're just getting into this, you're not going to learn everything you need to know tonight. You need to know that right up front. This is a process. It's a learning process. And this is kind of an overview of all of the steps and what we do and how we do it. But, man, this is on the radar for not just us as dentists, Guy, but how about people that have a commercial driver's license?
Yeah. The Federal Motor Carrier Safety Administration, so that's the department of the division of the Department of Transportation, a year ago or so decided that, hey, people who maybe screen high for apnea, we're going to talk about screening in just a few minutes, people who have hypertension, overweight, sleepy, maybe those people should be tested for apnea before they should be given an okay to be driving those commercial vehicles again. And a lot of times we talk about what a good idea that is in our seminars. Everybody agrees, but I think as dentists we have an obligation to do the same thing. And part of it is that we as dentists spend more time with our patients than our physicians. Most dentists know their patients better. Dentists see their patients more often. We spend more quality time with them. And not getting too deep into that subject, but obstructive sleep apnea is something that the anatomy that dentists understand and will learn more about. It's in your wheelhouse. This is not something that is outside of our realm of of where we should at least be looking and identifying these patients who are at risk. And I think this medical dental model, Rich, is why we started Dental Sleep Solutions. We were frustrated. We've been doing this about 20 plus years each between the two of us, roughly. And it's not much has changed since we started, and we were hoping to make a change. I think we have to some degree, but when you look at the number of people who are diagnosed each year, maybe 1 out of 10 are diagnosed, and way less than that are successfully treated. So SDB is sleep disordered breathing. For those new out there, if we had 10 patients who we thought might have that problem, so in other words, they may have apnea, snoring, not breathing well at night. Rich, when I first met you, that was what we talked about, is how do we get these patients tested? What was the only option we had, right?
Yeah, sleep study, PSG, that stands for polysomnogram. So that's the in-lab sleep test. And when we look at this and we suspect these people have it, Guy, what was the answer I would get when I first started this 20 years ago? I go to a sleep lab? I don't want to go to a sleep lab. Or, it's hard to get people to go to a sleep lab. How much is it going to cost? And, why would I be doing this? So we just don't get very many people to go. And this is the model that we've been using for a long time. And we plug these numbers in here, and we might have fudged them a little bit in our favor, but they're not that far off. So, if we're doing a good job screening, we're going to find that the majority of the patients we send to the sleep lab are going to have sleep apnea. And, what do? They say, here's your CPAP guy, good luck. That's pretty much all that happens. And will they wear it?
Maybe. Maybe, yeah, about half of them. I mean, some studies show more than that, but if you use the criteria, wear it most every night, most all night long, I think you're going to have to be pretty convincing to get it much higher numbers than we're showing here. And so the bottom line is the model before was, even if we were doing a good job of suspecting, which by the way we weren't, we can't get a lot of these people to go get sleep tests. And the ones that get the sleep tests get a CPAP, and to have those patients wear the CPAP every night, all night long, the number's low. Maybe it's not 1, maybe it's 2, maybe it's 3, but it's still, by most people's standards, it's not acceptable for this serious medical disorder. And I think when Rich and I first met, we're like, we got to find a way to help this. And we talked about starting our own sleep labs and educating dentists. And about that time, some standards started changing in our country, where home sleep tests became available, where instead of going to sleep lab, you can now go to your house and just wear something about the size of your iPhone or something like along that size. And now we can record all this data in your comfort of your own home. And as Rich and I started educating dentists, we say, can you get your patient to spend a couple $100 to wear a WatchPad home, or to go to Blackstone or sleeptest.com or one of these companies that we can send this to? How many now will agree to do that? And we feel that the majority of them will, if you're well educated and you believe in this. We do a good job of screening, so we're not just going to give these tests to everybody. So most people who have the device will in fact have apnea. And who will wear the device? Now, this isn't just our opinions anymore. They have chips they put in these, and the majority of the patients will wear these by Medicare standards, which is, what is it, Rich? 4 hours a week, 4 nights a week?
4 hours a night, 5 nights a week.
5 nights a week. Most of them will meet that.
Half the time.
Yeah, which is less than half the time. How many will wear it every night, all night long? Most of those will. And even if we're wrong, even if this is a 6 or a 5 and that's a 2 on the other side, we have an incredible opportunity to help this problem. And so that's what we're going to teach about these steps here tonight. A little housekeeping rather. If you registered for this, you will get an email. If you don't get it within 72 hours, check your spam to get CE for attending this evening. So.
Well, that's me on the right there. Guys on the left, like you said, we started this a long time ago. I do this all day, every day in my practice. Guy does this as well. We've been doing it for a long time. So we don't want to scare anybody away. We don't want to sound like we know everything. Guy and I know a lot because we made a lot of mistakes along the way. And, that's the best way I can put it. We're very real. We're very sincere about wanting to help dentists, and we're glad you're here tonight.
Right. We've done thousands of devices, and we hope to help you. We do these webinars roughly every Tuesday, and so one thing
Every other Tuesday.
Thank you. It's been a long day for me personally.
I hope you haven't changed that to every Tuesday.
Which something I need to tell you, Rich. No, every other one's enough. Roughly every other Tuesday. Thank you for catching that. And as you will find as we walk through these treatment steps today, this evening, you will see that a lot of this can be done by your team. We recommend that most of it be done by your team because you can be doing things like cutting crown preps or other dental procedures that only you can do. So attend next webinar, and we'll talk about who you need on your team and what specific duties they can take out of these steps that we'll be talking about tonight. The 4 pillars, we've been talking about this for quite a long time as well.
Yeah, everybody else has pillars now. We're kind of the trendsetters, I think. Everybody seems to copy us with everything that we do and we come up with. But, you got to find a way to screen your patients. You got to have a way to test them. Dentists we're always about the treatment part. Well, which dental device do I make for a patient? Well, we do some of those webinars as well. And of course, how do we get paid? But those are really the basics that you have to have down in order to get your arms wrapped around this and start doing it successfully.
Yeah, we're going to break these down into pieces, but if you have systems and team members accountable for each of these, what we call pillars, you will have a busy portion of your practice become dental sleep, and it'll be extremely rewarding and profitable. So here's basically the steps of dental sleep. And when I started doing this, one of the ways that Rich really helped me, because Rich had been doing this a little longer than I have, and I was just trying to be efficient. I had a dental practice. I'm trying to get dental sleep into it. I'm doing implants and a lot of things a lot of you dentists out there are doing today. And how do I do this and be efficient? And it originally took me several hours per patient because I was doing all this stuff myself. I didn't know where these steps are. And we'll walk you through these steps from screening, testing, consult, exam, delivery, follow-up, and 6-month annual recall. And of the dentist's time, this should take about 45 minutes or under. Not the first case you do, just like not the first crown prep you do. But if you'll use our systems and what we teach you, you can do this and do a great job. We're not doing sliding the patient at all by doing it this way. And the patients can be successfully treated most of the time. There's just a lot of parts to this. It's not hard, but the problem is if one of those parts, if one of those steps of one of these systems we go through today, you don't have down, you probably won't be happy doing dental sleep and continuing down the path of dental sleep medicine, and resulting in your patients won't get the care that they ultimately need.
Yeah, where do your patients come from, guys? We hear dentists ask all the time. Well, we talked about that oral cancer that you showed up there, Guy, earlier. 1 in 10,000, something like that, of people have something like that. And you got to remember, 1 out of 5 people walking through your door every day has this. So you don't have to go far for looking for these patients.
They're everywhere. They're sitting beside you on the plane. They're your dental patients. They're your friends. Don't forget your friends and your family, because a lot of them need your help. 1 in 5 adults. And I think, this slide is so simple, and you can put any quote in here you want along the belief lines. But if you believe this is an important thing to do for your patients and for your practice, and it's worthwhile, everything will fall into place. Because we can't make you believe in this. But Rich and I are passionate about our beliefs that this is something that we need to be involved with as dentists. And I think it comes down to why are you doing this? Why are you taking your Tuesday night away from whatever it is you normally do on Tuesday evenings and spending time with us? Is it just you're curious about dental sleep? Do you really want to implement this in your practice? Why do you want to implement it in your practice? Rich and I have stories about patients that, some of them didn't turn out so well prior to us knowing what we knew. And we have a passion about this, and we've seen the negative side effects of dental sleep, of apnea being untreated, and how dental sleep can improve these patients' lives. And I think, that's why I think you even have a couple of cases at your office, Rich, to remind you and your team.
Yeah. So all the cases that come in go on the left, and then when we contact the patient and they're scheduled, they go to the right side of the cabinet. And there's 2 people on the left, Guy, that they between the time we took scans on them and we could deliver their device, they died. So it bothers my staff that we leave those in there. But I do that to remind my staff of the importance of what we do and why we do it. So I think many times we do things, Guy, that make us feel good as a dentist. We get somebody out of pain, we fix their teeth, we make them look better. We do lots of good things, but this is at a different level all entirely. And I think your slide there, Guy, where your team is, we cannot understate the importance of getting your team to buy into this. So we would really encourage you to take your team to the courses that you do and things like that. I mean, we have built in a whole lot of education into the platform that we use and recommend, but your team is an important part of this, and we hope that you include them in this.
Yeah, and I hope that their why is genuine too. We're not trying to get them to, buy-in's the right word to some degree, but it's really spending a moment on the slide's important, because if you're doing this for the right reason, everything will turn out well. I mean, certainly you can make money doing this, and certainly it's enjoyable compared to some other dental procedures. But I think if you'll just treat a dozen cases with the knowledge that we can help you obtain, you will see why this is enjoyable and worthwhile. It's worth getting up every day for, and there's a lot of other whys that come along as just extras once you realize how important it is. So hopefully you can discover that on your own and have your own why. And everybody's is different, but if you have the belief in this and you have a why, and you understand that that this is something you want to do and this is your goal, I want to help my patients with this problem. Well, then you just got to kind of be calm and be prepared. Let's just have the right systems and tools and team education. That's what we can help you with, because if you believe in it and you have systems in place, we'll get you down the path of where this can be done real easily, routine, without a whole lot of interruption to your normal dental routine.
Yeah, but don't go running off buying a bunch of TV time, because these people are walking through your doors every day. We talk about the low-hanging fruit. I like to share the story, Guy, that, I've been out of school 3 weeks and I'm doing a mandibular block and I'm probably sweating, while I'm doing it. And this guy, he's asleep. And you know what went through my mind? Man, I'm good. I'm so good, this guy's sleeping. I didn't have a clue the guy had sleep apnea. He's probably going to die next week, I just thinking I'm good. It's this is a big problem, and there's a lot of people out there. So we hope you'll start, at least the process of getting involved in this. And
if you'll just do one thing, if you'll just go back and ask your patients 2 questions. 1, have you been diagnosed with sleep apnea? 2, are you wearing your CPAP every night, all night long? That's these ones in the basket down here at the bottom, because there are patients in your practice that will answer, yes, I have been, but no, I'm not. And I'll bet there's more than 1. I'll bet there's more than 2. I'll bet there's more than 3.
I'll bet there's 5 a week, Guy.
Yeah, there's a lot. And you can help these patients live better and live longer and help the practice grow at the same time. So it starts with identifying these patients and screening them. And, if you decide that dental sleep isn't for you, you'd rather be doing implants, root canals, or dentures, whatever it is you like to do, that's fine. But going with the ADA recommendation and with understanding where the anatomy is involved with I keep saying dental sleep, with apnea, you should be involved in at least screening your patients and understanding who's at risk and helping them get down the path of getting someone to be looking for that. There's a lot of ways of doing this, reviewing their medical history. When we do clinical exams, we can look at some tongue size and things we'll talk about in a little bit. Asking questions, you can do marketing to your patients. But really you need, see we have it highlighted in red, a screening tool. You need a quick and efficient way of doing it. When I first started doing this, I kind of took all these systems and I was like, I'd get busy and I'd forget about it. I'd get busy doing a root canal, crown, whatever we're doing, periodontal cleaning, and then we forget about this. So you need a system to say, all right, I'm going to look at all my patients with the idea of seeing who's at risk for having airway problems, and you need a way to do that efficiently and quickly. And I would even say that a way that you can do it, that your team can do most of the work for you, and then you'll have this well on its way. That system should include, at the very least, a medical history question. So the things down the left-hand side, we could spend half of a webinar, probably a full webinar, going through each of those individually. But you look at the people who are at risk, everything from AFib at 50%, diabetes at 48%, obesity, of course, we all know about, to the clinical side. While you're doing your exam, looking at their tongue, looking at their the angle classification, class 2, bruxism. And, we could just put these things up in our operatories and say, okay, I'm going to remember to do this. That's what I tried to do at first. And it worked well when it worked. The days that I wasn't stressed out because Mrs. Jones came in and their anterior bridge was broken that we did 6 months ago, those days I probably forgot to do this. So you really, if you need a system to do it more quickly than that. So whatever system you decide to use, we'll tell you how we do it with ours in a minute. You need a quick way to say, if in 5 minutes time, as much time as it would take you or less to do an oral cancer screening, this person's at risk for having an airway problem. Okay, more at risk than average. There's not some people will fall through the cracks. So in other words, we need to identify them and say, okay, this person's at risk. And then the second part comes in. This is where the team comes in, right? Rich, do you spend a lot of time talking to your team about verbal skills? And
I think this is one of the hardest things, especially for stubborn old men. What do you mean? So I quit breathing. Doesn't everybody snore? You'll get all kinds of comments like that. So again, we do role playing, we do word tracks, we do things like this. So those are all things that we help your team develop. But you got to walk through this. You got to get them, you got to find these people who are at risk. You got to get them to acknowledge, what do we want that person to say? Guy, what do you mean I might have this? Well, what can I do about it? That's what we're trying to get them to ask. And actually, there is something we can do. We can do a test. We can do an in-lab test. We can do an at-home sleep test. Which would you prefer?
Yeah.
So what I just said there is very important, because I didn't say, well, you might have sleep apnea. Would you like to do a sleep test? Because the patient's probably going to say, no, not really. Would you prefer to go to the lab or do a home sleep test? Most people will go, well, I guess probably at home. Well, which one does my insurance cover? That's the kind of questions you get, but it's not a no. So we learn to ask the right kinds of questions. So we're walking these people through those steps. That slide that Guy had there before, all we're doing is walking these people through these steps to try to get them treated.
Yeah, and if you tune in for our next webinar, we'll talk about some of those specific verbal skills and who will be in charge of the discussion between identify and test. And that's probably the most difficult. I'm not underestimating it because of the stubborn old men like Rich described. But it's doable if you believe in it and you have the right systems in place to do it. And then eventually, of course, we want to treat the patients. But that's the easy part. Most of you dentists, when we start talking about taking impressions and bites, that's the part you can do. And of course, we probably want to talk about medical billing somewhere along the way as well. But the first ones are important. Through DS3, we'll talk a little bit more about this towards the end. But we have systems in place that can help this be very, very simple. We have a cloud-based screening system that you just pulled up on a tab or a tablet or a computer, maybe even an iPhone, I guess would work, but the print may not be quite big enough. And it just walks those patients through those tests, questions rather. And at the end of the questions, in a couple of minutes, it identifies their risk. And if they're at high risk, they get something that looks like this on their screen. They're holding a tablet in their hand going, what does this mean? And we can walk you through the verbal skills on what you would say to that patient on, well, yeah, you're at risk for airway problems. We would hit the view results button down here in the bottom of the tablet, and we would look at all the reasons that they were at high risk, and you or someone on your team, ideally, who's been educated in how to have these conversations, will talk to patients. And it really comes back to any reasonable person, if they understand they could die in their sleep, have a stroke, have hypertension, get diabetes, be impotent because of this not breathing well at night, they'd probably want to at least know about it and maybe do something about it, especially when a test is a couple $100 or less done out of their home. So again, we could spend all night just talking about these verbal skills, but I think the key things here are, we don't tell patients, hey, we think you have apnea, any more than you would say, I think you have cancer, without a diagnosis. We try not to talk too much. We try just to get them to come to their own conclusion that, hey, I may not be breathing well at night. And what do I do about this? Well, we get you a test, and we relate it back to the red flags when it comes to it. So when they finally do say, yes, I'd like to know about this, I think that one occasion where that chain breaks is people don't have a plan. They go, oh, we could do a home sleep test, I heard. Well, how do we do that? And then they call up, hey, Jane, do you remember how do we had one of those companies we can refer them to, or do we have one of these machines around here we can give them, what's that thing called, and you act like you have, what do you always tell me, Rich?
Fake it till you make it.
Fake it till you make it. At least have a plan and act like you know how you've done it. Now, here's the really great news, is this is a lot easier than it was when we started this, because the only plan we used to have was, let me call you to my buddy down at the sleep lab, and you're going to go spend the night down there. And they say, sure, I'll do that, and they don't do it. But now we have a plan, and the plan for testing can still be going to that sleep lab, which certainly is indicated at times, and some patients may opt to do that on a rare occasion. But I think most patients would rather just wear something like this WatchPat home or one of the other home sleep testing devices and get a test. I think now that barrier, that hurdle has gone way lower for the dental offices to facilitate this. And if you're going to use a home sleep test, you can still refer them to a sleep lab to get a sleep test, and they do home tests there now because they're forced to due to insurance and other reasons. So the number 3 here, certainly if you had a physician that in the area that you want to work with who had a sleep lab, or maybe even a primary care who would dispense home sleep tests, you can do that. But as a dentist in most areas, we have a couple other options which are even easier to do. One is you can buy your own home sleep testing unit, dispense it, have a physician read it and give a diagnosis. And the other is you can work with a company that does this for you. In DS3, this is the cloud-based management system we use for our dental sleep patients. We just click a little button that says order home sleep test. And what happens from there is one of the companies that we work with, Blackstone or sleeptest.com, they actually contact the patient. They work out the medical insurance because it's already been transmitted through this DS3 system. They bill the patient directly. They mail them the test. The test is worn by the patient. They mail it back. A physician reads that information, and then a diagnosis is given to the patient. And really, as far as the patient goes, they're not giving you money. They're paying the diagnostic company. And in most cases, insurance covers a lot of it. Even if they don't have any insurance, it's a few $100s. Or less. And again, the other one is you buy a unit yourself. So that hurdle, I mean, I would say of all the things that have happened in the last 10, 15 years, that was one of the ones that's probably made dental sleep in particular,
biggest difference.
Biggest difference, a lot easier.
But a very big part of that, guy, is have a plan part.
Right.
So you had a plan there. You didn't
Right.
just say, well, why don't you ask your doctor about it, or why don't you do this? So we talk about our word skills, and don't talk too much. Hey, let's get you tested. We've got a system for doing that. We're going to go ahead and get that set up. They'll give you a call. It'll show up at your home. Let's make an appointment for you in about 3 weeks, and we'll go over the results of that test, and then we'll talk about what we can do. But it doesn't take too long, does it? And
No.
we're just walking that patient right down that rosy pathway.
One thing you said too, Rich, the way you said that is a way a physician would say it. I think as dentists, we seem to always be asking our patients for permission and so forth, which I understand you have to have informed consent and things like that. But I don't think a physician typically goes to their patient and says, you may have a blocked coronary artery that may kill you. And
what do you think about?
What do you think we should do? Should we send you in to have a should send you in to have a test on that? What do you think? Would you like to do that? They just say, hey, you need to go down to the stress lab and have a test because we think you may have a heart attack. They don't ask permission. They don't they assume you don't want to die of a heart attack, basically. And this is as serious in many cases. Rich has a couple of cases on his shelf to prove it. So, not to prove it, to remind us, rather, would be a better way of saying that. So, be mindful that we as dentists look at this differently. And I think it's worth trying to understand the different mindset. If you just go at it with that attitude, hey, we need to get the test, which one do you prefer? They will do the test. Rich and I can go in your offices and get your patients to do tests when you're struggling with it. And it's it isn't really wonderful.
Simple, isn't it?
Yeah, we're not that. I mean, I've already misspoken a half dozen times tonight. We're not that articulate. It's that we believe in this, and the patient understands we believe in it, and it's the way we handle the conversation with the patient that they go, oh, I get it. Let's go do this. So, all right. So, I mean, if you get through those steps, I mean,
yeah, you got half the battle, down. Those are the biggest hurdles. So, a lot of things that dentists have the most questions about and what they do is really the easier things. Right. So, you got to have a system for doing this. This is why Guy and I started Dental Sleep Solutions. This is why we tell everybody you should use DS3, because this is part of our system. We're talking about how we screen people and the questionnaires and all the forms that we need and how we order tests and what we do. We just walk right down through here, and then we got to have a way to keep track of all of this stuff. Where do things go? How do we monitor what they're doing or not doing? We have the letter writing in there, and we look at that. Guy, I pulled up my DS3 software, January, February, March. You know how many letters come out of my office? 1,650. That's how many letters we wrote out of my office in 3 months. Wow. So, yeah. But again, that all of these things are ways of connecting the dots. So, again, we're not trying to scare you off if you're just new into this. We're just trying to help you get your arms around it, and we're trying to help you figure out. I know in the questions there, Guy, Dr. Hill said just in the last 2 weeks, she's already had a couple of people that she asked and she found because they were diagnosed and they're not wearing their CPAP. So, right. Again, those people are there, and let's just get this thing started. Let's get it rolling.
Yeah, and I see questions coming through, and I know our team and Rich are answering those questions as they come through. We will get to all the questions before the night's over, so keep them coming. We had several hundred people register for this tonight, over 100 people on here, so we can't open up the mics, but we'll get to all the questions, either type them in or verbally before the evening's over. So keep it coming. And again, when you look at the screen here, one thing I want to point out is, dental softwares, dental charts, dental management systems don't have places to put this stuff. They don't have places to make this more an efficient process. So however you do this, you've got to find a way to manage all this, including, as Rich mentioned, the communication, because you can't treat a medical disorder without communicating with the patient's physicians. We would never recommend that. We want to expedite the process by getting them tested, but we certainly, the primary care and the other physicians need to be on board and understand what we're doing. So all those things you got to find a way to do, and that's what we do at Dental Sleep, is we help you put those processes into place. At Dental Sleep Solutions, our DS3 system, we talked about the screening, testing, treating, and billing. Well, we help with those through education, coaching, software, and support. And we provide the best of anyone in the country for all of those. And we pull all that together into a simple system to make you more efficient. So we can talk more about it at the end, but if you're interested in learning more about how we can help, or even if you just have a quick question or even a long question that you need help with, just type in consultation. We have dental sleep medicine trainers. That's what they do. They get up every morning to go to work. They've been doing dental sleep for a long time, some of them pushing a dozen years, and they can help answer your questions, and they'll be happy to do it at no cost, just to see where you are in dental sleep and show you how we can help you. So type in consultation at any point here tonight, and we'll be happy to schedule Jody Brandy, one of the dental sleep medicine experts, to give you a call and set up a time to go over that with you. 3 goals. There's 3 goals. I like goals. I think I'm a goal-oriented person. Typically, I don't do well unless I know where I'm going. I think one of the biggest mistakes people make with dental sleep is they don't think about this, because every patient's different. And if you'll break it down with your patients, we're talking about the steps again of dental sleep. We've got to decide, what are we wanting to accomplish here? Okay, what's the number one thing? Why are we doing a dental device instead of a CPAP? because they'll wear it. Hopefully, it's where we shine. And if they don't wear it, whether it's a CPAP or a dental device, we're not going to accomplish anything for their airway. This doesn't cure sleep apnea. We just treat it. So the first goal is we want to make sure our patients wear this every night. And so as we deliver devices, we go through that with them. And then I think one of the things we do a little bit better than CPAP, what'd you say, Rich? They give you a CPAP and say good luck?
If you're lucky, they say good luck. Usually they give you a CPAP and go, it's $642.18 is your copay.
Yeah.
You know, so yeah, you got to wear it. Is it working?
Yeah.
How are you sleeping? How are you feeling? You know, we just do simple things in my office. Every time a patient comes back, Guy, are you wearing it? It's the first question we ask. If they say no, we say why. But how are you? You're snoring, better, same, or worse. Your sleep quality, your energy level. We always tie this into their chief complaint at the beginning. You know, I have morning headaches. Well, do you still have morning headaches? No, actually, I don't. I hadn't even noticed that. I haven't had a headache in a week, you know. So you got to get them to wear it, subjective improvement. And then we want to put some science behind it. So we want to get to objective success. So when we look at that, we got to measure something. So with the subjective part, we're just asking questions. You know, in an ideal world, Guy, I'd make a dental device. We'd move them forward 3 millimeters, wear it for a week, test them. 4 millimeters, wear it a week, test them. 5 millimeters, wear it a week, test them. We can't do that. Nobody can afford it. Nobody has the time or the wherewithal to do that. So this is the second best way, is you just ask them, and then we get them back for a follow-up sleep test with their dental device in place. And that's, I tell my patients, Guy, that's what helps me sleep better.
I like it. That's
people say, well, I'm doing great. Why do I want to do that? I said, because it helps me sleep better. You know, you got severe sleep apnea. I want to know that this is working. I'm so happy for you that it's doing great, but we got to put some science behind it and do that.
And I would mention 2 things on this. These goals, other than wearing it's the goal for everyone. It can be different. Sometimes the primary goal is to help the snoring. Maybe their apnea is not that significant or severe. And so identifying for that particular patient what these goals are at the consultation is key to success, so that we can sit down with the patient and say, here's what we're likely going to accomplish, here's what we hope to accomplish. We write that down, and then we can refer back to it, because it's different for every patient. Someone who has severe plus apnea, we may not alleviate all their apnea, but the goal may be to get them down to mild to moderate apnea, even because they can't wear their CPAP or for whatever other reasons. And one thing else I'll mention, Rich, when you said something about the CPAP, you said we give them a CPAP and say good luck. You know what they do is they give them the CPAP, they crank it up until they have objective success. So in other words, till the apnea is as good as they can do, and they say, we hope you feel better, hope you wear it. They do this exactly the opposite. And I think one of the reasons people do wear our devices more is we go down this way. We coach them on wearing it. We coach them on symptoms. And once they're feeling better, you don't have to tell them to wear it anymore. They're gonna wear it because of how they feel. So again, here's the treatment steps that is worth putting back up on the screen. Again, as we walk through this from consult, exam, delivery, through wake evaluation, titrations test, and so forth. So we'll go through each of these fairly quickly, just so you understand what the basics are you need for the consultation. The consultation is important, again, to identify what our goals are. And in order to identify what our goals are, we need to know those 2 last subjects, what the patient's baseline is before we treat them. So in other words, the objective, that's their, the third one on the previous slide. So that's how bad their apnea is from the sleep test, and what their symptoms are. If we know that prior to even talking to the patient, boy, we can have a much more efficient consultation, as opposed to walking into the consult room and going, you had a sleep test, how bad's your apnea? Oh, what do you want out of this? I don't know, my wife's made me come. I mean, if we have a way to get all this information prior to the consultation, before they ever walk through the door, you're going to save tons of time and do a far better job. And then the other thing you absolutely need to have before you have a consultation is an idea of how to discuss what it's going to cost. And if you're dealing with medical insurance, you certainly need to have a way of knowing that ahead of time. So we can spend.
Do your patients actually ask you that, Guy?
What's that? How much?
What
They
is this?
just trust me so much. They say, I don't care what it costs.
You're the man. Yeah,
No.
I do 5 to 10 consultations every single day in my practice. Every single day. And every single patient has the same 3 questions. Will it work for me? How much does it cost, and what does my insurance cover? So again, this is part of that system that we're trying to get you guys to buy into in your team. So when Guy talked about prior to the consultation, we may have had a talk with somebody in a consultation room because we gave them the DS3 screener, and what can I do about this? Well, we're going to get you tested. Home sleep test? Yeah, we're going to get you set up. They're going to do that, and then we'll talk in 3 weeks. So we already have that done. So verify that it's a baseline test. Sometimes, Guy, when we ask for these, they'll send us the CPAP titration study. We used to go to a sleep lab, they'd spend a whole night baseline, and then they'd go back the next week and they'd do a CPAP titration. Payers are getting smart. They don't want to pay for those 2 tests now. So sometimes they put them together in what's called a split night test. But at any point, make sure it's a baseline. At least it has a portion of it. Make sure it's not more than a couple of years old. There's no hard and fast rule on that particular one. But you got to have a place for this. Where do you put this stuff?
There's no place in their dental practice management softwares for this. So we have a place for it to where it jumps out at you, so you can tell at a glance that this person has almost 30 events an hour. And if you order the test through DS3 and click the little button, it just pops right back in to DS3. The test does in this particular fashion. So we could spend a lot of time going through what all these AHI and RDI mean. If you don't know, attend our other webinars, think about coming to one of our courses. But basically, that's the level of apnea that the patient has, and we need to know at a glance what these things are. We can't be looking through a 10-page sleep test with the patients before the patient walks in or while the patient's in the chair. Same thing with the symptoms.
I can't tell you, Guy, how many times, if I just take 2 or 3 minutes to put that stuff in and review it, I can't tell you how many times I have patients say, man, I can't believe how well organized you are. Right. Has anybody ever gone over your sleep test with you? No, doctors usually don't. Nobody's talked to them. So, but your questionnaire has to have some stuff in there on subjective. What is your chief complaint? Why are you here? What have you tried before? Where do we get some of that stuff? How do you ask it? Where do you find this stuff? Well, our system has all of that. The Epworth, the Thornton snoring scale. We look at all of these things, and we're trying to find a placeholder. Not only do we ask this guy, but we actually ask some of these on multiple visits. So we have to have a way of putting that stuff in there.
And again, we want to get this before the patient comes in so that we can walk in the room going, hey, Mrs. Jones, thanks for filling out that information. I know from the information that you filled out on our web portal before you came in, or forms if you had to send them to them for some reason. We know that you're snoring. We know that you're sleepy. We know that you've been tested and your level of apnea is such. And in a matter of 2 minutes, I can discuss with that patient the details of what's going on with them. I've never even met them until just that moment. And they're like, wow, you understand what's going on with me more than anybody else has, just like Rich said. And it's because we're organized. We organize all this into a summary sheet here, as you can see with our patient, Pat. Of course, this isn't a real patient, but we can put it all on one page. And then we can also break down all those things that Rich talked about, the Epworth, the snoring. And again, if some of these words you don't know what they mean, we can certainly help educate it. Type in the consultation, and we'll review this with you. Tune into other webinars, or come to one of our seminars that are coming up, which we'll talk about at the end tonight. Snoring levels. And so we can track this at a glance. We can see what's going on with this patient, and we're going to refer back to this as we treat the patient. And again, the third part of this is that we need to have a way to
verify benefit.
Right, we need to know, and ideally with the click of a button, where the patient is with their medical benefits. And through DS3, we have a quick, easy way with over 4,500 billers. We can tell exactly what their patient's medical benefits are, and tune into one of our billing webinars to talk about how we use this particular information to come up with a treatment plan for the patient as far as how much out of pocket they can expect to pay for their particular case.
Hey, Guy, there have been a couple of questions, Guy. I know I'm kind of monitoring this while you're clicking through the slides about what patients want to know what it costs, how much does it cost insurance. Again, That's a whole nother webinar. So you got to remember, we're just kind of blitzing through some of this stuff, and those are important things. So we would encourage you to look up some of the other ones that we have archived as well on YouTube and things like that. But Guy, you're so goal oriented. I love the way you put these slides together. You know, what's going on with this consultation? Well, we were going to review their health history briefly. We don't want to know about every single ache and pain they've ever had. The sleep history questionnaire is very important, and you have to have that to go through it. So, you know, go over the sleep test. I like what you say, Guy. Don't use big words. Don't use apnea. You know, hypopnea H. I kind of say, well, you know, every time you do that, how many times you quit breathing? And the spouse always laughs and goes, "That's exactly what he does." You know, so, you know, this is sleep apnea is bad. Usually I will say something, Guy, at the screening part. I'll say, look, I want to challenge you, Guy. I want you to go home tonight and read about sleep apnea online for 30 minutes.
Well, that's a good idea. Yeah.
Yeah. So by the time they come back for the consultation, I start going into the health risks, and they go, "Oh yeah, I read about that, doc. You told me to read about that, man. I just want you to know I didn't make it 30 minutes." I was like, "Oh my gosh, I can't get this test fast enough," you know, because of all of these things. So we've got a copy of that, and then we just look at what are our treatment goals. You know, what can we do to help you? Do you have enough teeth? Can you move your jaw? Can you do that? Because we're trying to establish if you're a good candidate for this or not.
Yeah, and again, the goals that I think are most important to establish are, what do you want out of this from a subjective point of view? Snoring, decreased sleepiness, and like you said, Rich, what's your number one thing that this device could do for you? Ask the patient that question, and then if you ask them that, if we can only do two things, what would that be? And then also for us, what that sleep test, you know, where those numbers are and where they come back. So again, once we're finished with our treatment, we're going to retest the patient again, as we're going to show you in a little bit. So we want to know what the goal was to obtain there. We're not going to spend a ton of time on the patient examination, because you all know how to look at your patients. We will mention that you do look at this a little differently. You're going to look at their soft palate. You're going to look at their tonsils and see how big they are. Describe how their uvula is, their tongue, mandible, if it's narrow, tori. And the goal of, while we describe these things, you can do this in a long SOAP note, but we have check boxes in DS3 to quickly make this process much more efficient, is to document what is going on with their airway from a collapsibility, from an anatomical breathing airway concerns, such as, again, tonsils and tongue size and so forth, but also to help determine which device we may want to use based on the anatomy as well, because certain devices work better. We will visit that at a future webinar as to which device we use. And of course, we want to look at their jaws and make sure their muscles aren't sore. If they are, that could affect things. And then we're going to measure how far forward the jaw can move backwards and forward, and then take a bite at a protrusive forward comfortable position, not all the way forward, not 70, 80%, or, you know, it's you know, with a little bit of experience, a little bit of luck, we start them back at a comfortable forward position. But understand, we can go more forward. So if we not quite there, that's fine, because what's the first goal? Wear the device. And if we go too far forward, they're not going to wear the device. So we start them back here, and then we can walk them forward based on their symptoms, and eventually on these follow-up sleep tests. With the device delivery, yeah, I would say this is probably the easiest part for the dentist. I mean, if you can,
that's right up their wheelhouse, right? You put dentures in, you put partials in, you put crowns in, all that stuff. I like your part about the guy explain that it will feel a little bit tight. You know, I always say my hardest part is too tight or too loose. So that's, you know, it should feel like a good boot. That's what we say here in Texas, Guy. You know, you put your boot on and it goes on kind of snug, but once it's on, it feels nice and good. So you're going to evaluate that, make sure the patient knows how to put it in, take it out. We're going to make them a little AM aligner. We call it, that's a bite recapturing tool that we use, because when we move their jaw forward, when we take your dental device out, we want to get your bite back. So we have a video that we developed, Guy, in my practice that's 5 minutes long, and we just walk them through all of this, and then we do each of those things, and then we do all of this. So we've got the got the process down pretty quickly on the
Yes.
device delivery part.
Yeah, and again, that's probably the part you'll do the best because you're used to delivering partials and bite guards and so forth. So when they come in for their first evaluation, which we recommend usually around 3 weeks or so, because that way they've had time to get used to it, to see if they're wearing it. And most of the time they will have been wearing it. In my practice, they are. I mean, sometimes they haven't, but our agreement is if they're not going to wear it, they need to come in sooner than 3 weeks because there's something wrong. And whatever the reason is, fix it. If it's too light, usually it's pushing on some teeth or causing some discomfort, you make those adjustments. So in order not to spend a ton of time on that, we're going to move on to the part that you're probably not as familiar with. Is it working? Well, how do we know if it's working? I'm going to show you, we're going to walk you through that in just a minute, but we start with those symptoms that we identified at the consultation. And if we've not reached our goals that we identified, then we're going to move the device more forward. Okay, and then we're going to come back in a week or two later, either with a phone call or in person, and ask them again until we feel like that the device has accomplished those subjective goals. And then we're going to move on to the objective. So we do that very efficiently through DS3. I'd say this is one of the things that has saved me between getting the two things. I would say the sleep tests being in order, where you could just glance at it, like when we click the button and send it to sleeptest.com, and it just pops up there, and a questionnaire, and then having these symptoms, be able to come back later and just compare right back to those. It just saves a ton of time as opposed to looking through a 10-page questionnaire and another 5-page questionnaire and 2 or 3 sleep tests. So we look here at the symptoms, and at a glance, if you know what ESS is, Epworth, that's how sleepy they are, how much they're snoring, we can see where they were, and then we ask them the same questions again. We don't tell them what they answered the first time, and we refer that back to what their chief complaint or complaints were. And if it was snoring, in this particular case, it went from a 19. If it was sleepiness, it went from a 19 to an 8, and the snoring went from a 12 to a 4. So if those were the 2 chief complaints, we'd say, hey, John Doe, Mr. Doe, it looks like you're done a whole lot better here with the snoring and sleepiness. How do you feel? Have we accomplished your goal? And they're going to say, in this case, most likely, yeah, I'm great. I'm happy with this. Well, then we're going to follow up with a sleep test. Now, if there wasn't, we would adjust the device, move it more forward, a small increment over time, let the patient do that in many cases, and then we'd have them come back. We would add another column here. We could even just do this over the phone in some cases and see how their symptoms are. And then when we're finished, we're going to make sure, what did you say you did this part for, Rich, once their symptoms are in good condition?
Yeah, we want to get them to do this follow-up test. And I tell people that's what helps me sleep better, just knowing that it's working. So, here we have a beautiful way of, we did 3 nights. So on the far right, we have the baseline sleep test. So, again, the AHI, RDI, these are all numbers of how many times you quit breathing. When we put your dorsal device in and we had you at, a certain setting, we got the number from 29.5 down to 19. We adjusted it a little more. We got it to 8. We adjusted a little bit more. We got it to 6. Your O2 sats are better. So everything's looking good. Again, this is a very simple way to organize this information so that we can look at it and see. You know what else I find, Guy? I have a big monitor. I got a big 27-inch monitor in my consult room, and I kind of turn it, a little bit like that so the patient can see that, and I pull this up and I go, look at how you've improved, because so many of us are visual learners. If I just say those numbers, they're like what did you say? You just throw all these numbers around, they don't get it. But I go, look at how you've improved at each one of these positions.
Yeah, that's fantastic. And if this was individual sleep tests, they may be 2, 3, 5 pages long. You may be looking at anywhere from 12 to 20 pages you'd be looking at. And again, one of the questions that comes in is how do you determine the follow-up sleep test? It comes back to the consultation. At the consultation, we talk to the patient about what to expect, the procedure, and we say we're going to need to follow it up with a sleep test, and we talk about how that's going to be accomplished. If it's going to be accomplished with an ambulatory company like sleeptest.com that we use, then we let them know, hey, we're going to use the same company we used. You're going to get a device mailed to you just like you did during the screening process, and Sleep Test will send it to you and bill you directly. So that's the expectation that there might be an additional fee for that, but again, their insurance may cover a lot of it as well. So we don't want to just tell them about this at this point. They need to expect this is part of the whole treatment process. If it's a PSG we're going to follow up with, well, then let them know that. I mean, that's not real often, but sometimes in our office, that is the protocol based on the physician referral, and that's what they want. So we'll follow up with that. So I don't think, Rich, in order for time, we might want to go through some fairly quick because we want to have time for these questions that we're getting, and we're going to get to them all. But we should see our patients at least once a year, maybe 6 months after we first deliver the device, but then once a year to make sure everything's going okay. Because apnea gets worse with time. The devices can break. They can quit working as well because patients gain weight and their apnea gets worse. And we need to reevaluate how well this treatment's working for them. A patient wouldn't just get blood pressure medicine and just have that prescription for the rest of their lives and never go back to the doctor to see if it's working. Same thing here. And then I think we're going to talk about two more things before we finish and get all these questions. One is communication. Rich, how many letters did you say you'd sent?
Like
1,600?
690. So yeah, we're sending out 700 a month. So, and who do you write them to? Well, we find out, Guy, in that part of our questionnaire and part of our portal in DS3 is we get the patients to do this online. They get to fill the forms out in the convenience of their own home. And we get all of their doctors, we call it the best MD, Guy.
Right.
Who's your best MD? Well, what do you mean by that? The one you have the best relationship with. Well, I never see my primary care doc. I always go to my diabetes doctor. He's the one I see every, at least once a month, sometimes 2 times a month. So we certainly want to keep him in the loop. I went out to the medical facility at the Army base here the other day, Guy, and I got to do a grand rounds with the doctors, and they said, "Man, you are the guy." Well, why do you say that? Well, thank you, but why do you say that? Man, we don't have to wonder how our patients are doing. You give us these progress notes. I just want to know, is a patient wearing it? How are they doing? And you keep it simple and you keep us informed. So we cannot underestimate the importance of
it's your obligation to do it too.
Yeah.
It helps you with your marketing and all that, but you need to communicate with physicians and you need a system that makes this easy. If you had to hand type all those letters in Word,
forget it. You'd never do it.
Take all this information. DS3 takes this information, plugs it right in. The sleep test results, the Epworth results, the patient's names, all that stuff, and it digitally faxes them through the cloud for you, so you don't even have to put a stamp and save a tree by doing so. So lastly, in order to do this, you need to bill. And we will be doing upcoming this year webinars on just billing. That's a hot topic. We do at least 1 or 2 of these a year. And so I think just the take-home messages on this are, if you're going to be doing dental sleep, you're going to be helping patients with apnea with dental devices, then now you're doing a medical procedure with a dental solution. And it's under different guidelines. It's totally different. And even though you're familiar with everything dentistry, from root canals to crowns to implants, you may not be a pilot, and you may not be an attorney or a CPA. And my analogy here is, just because you think you know about dental insurance billing, you might as well be your own pilot or CPA or attorney, because you don't know anything about medical billing. It's totally different. It's as different as dentistry is to those things. And so our strong advice, we work with about a half dozen third-party billers who specialize in dental sleep, and we'll put our information up again, or just type in consult tonight, and we'll be happy to talk with you about hooking you up with one of these third-party billers that they do this billing for you. Either that, or we will educate you through our webinars and CE courses that stand back from this and don't do it. Just don't do medical billing. But if you're going to get involved in medical billing, until you know how to handle everything on the screen here, from in and out of network and billing systems, you need to let someone else help you with this. So those are treatment steps, and we went through them fairly quickly, but I think we gave you some valuable information. If you missed anything, type in consult. We'll meet with you, answer any questions. We'll continue to answer these questions. But I promise you, if you'll do a dozen or so cases with a system we can help provide you, you will be able to do this in less than an hour's time of your doctor's time. Ideally, it should be less than even 45 minutes. I know Rich and I are down to 30 minutes or so because we have great trained teams, and it doesn't require most of these things teams can do. So tune in next time for the team webinar because we can talk about how they can make it efficient. And we talked about the why earlier, Rich, and I don't like to emphasize the money because I think the why hopefully comes from this is the right thing to do. It's a wonderful thing, comes from the heart, but it doesn't hurt to make money either. And there's nothing you can do, in no service you can add, not something you can tweak in your dental practice that has a higher revenue potential to increase your practice revenues than dental sleep. There's just nothing out there. It is a practice within your practice ready to explode. And even if you just do a device, a month, it can add nearly $20,000 to your bottom line, even if you pay for DS3, a third-party biller, and your lab fee. I mean, that's a lot of money just from doing one a month. You have to be not trying to do one a month. If you do one a week and take 4 weeks off, it's pushing 6 figures. What, 90,000 there? That's a lot of money to be adding to a practice to do one device a week, and we have to, the offices like Rich that do 5 a day. So you have to have a plan for this. I think Rich made this slide, and I love it because you can't just go on without the plan. I like to mention again, that's what we do. We help dentists with the hurdles that they need to do to accomplish dental sleep. And one of the questions that comes up sometimes when people do these, say, I'll schedule a free consultation is, what does your services cost? What we decided to do was the beginning of this year, it's been about maybe 9 months ago, something like that. We decided to do an introductory service where it's a little over $1,000 for 3 months, where you have access to all of our education, to our team, to our services, to our software, to all the archives of these courses and all the other ones. And we actually walk you through what we call our DS3 experience. We take, here's your team, let's teach you what you need to learn. We actually are almost like, I would say, what health coaches or gym, personal trainers. I can't hear you, Rich. You must be muted or something. Personal trainers, there you go. Personal trainers or something, to where we're run the borderline between helpful and annoying, where we'll really be on you to try to do this. And in 3 months' time, most offices, if they follow the procedure, will be doing at least one device where they got paid for. They'll be doing more than one device, but they'll go through all those steps. They'll be getting paid for one device, which pays for more than typically a little over $1,000 for the introductory. So if anybody's interested in that type of consultation, we can talk to you about how we can help. And it's the best bargain in dental sleep, and we're big believers in what we do, and that's why we do it for that amount, because we know that most of you will value that service, and the people who want to do it will succeed. It's much, much easier when you have a coach and help doing this than trying to recreate the wheel.
Yeah, I keep trying to get Guy to go to that, Ghostbusters theme song, who you going to call, because you really do. You have 1,000 questions about how to do this, and you don't have to reinvent the wheel. For what you will pay us to help you do this, it's one dental device for the entire year, just about, or 2, depending on what you do. So you don't have to reinvent the wheel. I think that's the best thing. Guy, I was laughing. I didn't know I was muted, but about you do one a week, you can almost add 6 figures. That you can almost take your family of 4 to Disney World for that for a couple of days, right? Gosh, I can't believe what that costs. Go ahead, Guy. One more thing, and then we'll go over some of the questions.
Yeah, we'll finish these questions. One thing we'll give you for free here. This comes out every other month. Go to this website here, and we have some of the country's experts giving a digital magazine. It comes right to your inbox. Doesn't cost you anything. We have great articles. I typically do a video. Rich writes an article. We have some of the country's experts who write articles for this. And it's real practical information that can help you. Again, here's what we do. And last thing, I think we've mentioned the courses. We do courses all over the country. We do mostly 2-day hands-on courses. So where you actually get a dental device made on you or one of your team members. You actually get a sleep test on yourself for one of your team members, where we review the results. You can go through the process. You have hands-on training on taking the bite and making that repositioner Rich talked about. And it's $1,000 for the 2 days, and including the CE.
You can't even get diagnosed and treated for that, guy, anywhere in the country. So,
And here's where I'm going to give you a heart attack. We give $200 off for anybody who attends these webinars. So that includes you and one team member even. So, I mean, it's the best bargain in dental sleep. I promise you, I teach a lot of these myself. Rich teaches some of them. You will leave there saying it was well worth your time. It's very practical on how you do this, and it's a great hands-on experience. They're typically on Fridays and Saturdays till 1 or so, and all over the country. We have some dates listed here, but we're adding more. So if you're interested, type in course, and that'll secure you the $200 discount. So $795, you can get all that. So type that in if you're interested, and then Jody or Brandy will get with you about where you want to attend. And we'd love to see you. We have one coming up here in my backyard. We only do about one every year or year and a half in my backyard here in Tampa. Here in a few weeks, we got quite a few people come to that one already. So hopefully we'll see someone there. And then, Rich, our symposium was a huge success this year, and I'm looking forward to next year already.
Yeah, I love that slide Jason put together. 10 things you need to know. It will sell out. So the first year we capped it at 300, the second year at 400. So I'm not sure what we're going to cap it at this year, but it will sell out. And the thing I want to say about that, guy, is it's practical information that you can use. There are other dental sleep meetings out there, but I think for the kind of dentist who's really just trying to learn how to do this better, that's why we get such good feedback about that. So we hope you'll certainly consider that. We did have a thing in there on the FDC. Some of you in Florida we'll be doing a hands-on thing as well there too. So we got a lot of these that we're doing all over the country. So we would encourage you to find one close to you and do that. The best part about the symposium, it's in February in Florida. So for some of you snowbirds up there, that's a good way to do it. So
if you want more information about the symposium, just type symposium and someone will get you registered, or you can go to the website that was listed here. I'll back it up one more time for the symposium. Okay, go ahead, Rich.
I hope you'll join us in a couple of weeks for the next one. So, Guy, a couple of these things, questions I'm looking through here. I want to make sure everybody understands. So the hard part about this, so there have been 3 or 4 questions on this, is, I get some kickback from my patients about doing that follow-up sleep test. I get that. I always get that kickback. That's why the verbiage I use, this is what helps me sleep better. So, if they have mild sleep apnea, the respiratory disturbance index, that RDI is under 10, it's really not our call anyway. We're helping co-manage this disease with the patient's physician. So all we can do is make a recommendation. Look, Guy, you're at the point where subjectively we have improvement. Again, CPAP gets the advantage of doing this in a sleep lab, and they just turn that knob until the events go down, and they say, okay, here's the CPAP pressure, good luck. We do it the opposite way. We start them at 0, and then we move their jaw out, but we don't have the advantage of doing multiple sleep tests. So that's why we have those questions. That's why we want to try to get that patient dialed in. The particular example you saw there, where we had a couple of different tests tested at different positions, some of the home sleep testing companies will do multiple nights. So you can have the patient tested at different positions. That's another thing that you might consider doing as you look at this.
Yeah, and I think, like you said, it comes down to the verbal skills too. I mean, the patient, if you're talking about screening a patient, remember we talked about how the second step, the acknowledgement, is the hard part, and it's I don't know that it's hard for the patient. It's hard for us to get over that hump as we educate our patients. Yeah, do you need to get credentialed? Someone just answered that. It looks like you do, but that's what the third-party billers do for you. It's not it's a little bit involved process, but it's something they do all day long. We can certainly discuss, if you want to try to do it yourself, how you do it. Certainly get in touch with us there on that. Again, the next webinar is April 17th. All these things we just talked about, most of which these steps can be accomplished by your team. So we'll talk about who those team members are. There's our contact information too. So let's see, Rich. What are the questions? It looks like you all.
A Yeah, a lot of the questions, Guy, are around the home sleep testing and that kind of stuff. So we get that. I think if you're screening your patients and you're seeing this, that's kind of the first hurdle that we see as dentists, isn't it, Guy? Because that's where you said have a plan.
Right.
You know, have a plan for how we're going to do this. And again, this is a 1 hour topic, so we can't answer every single go through every iteration of this. But remember, Medicare patients are different. So if you have a home sleep test unit, contact us. We will help teach you how to use that in your practice. Mm-hmm. If you don't have one, you don't have to go out and buy one. I wouldn't recommend that you do until you at least know what you're doing and how you would use that in your practice. So that's a little bit different about how we do things. Is we don't tell you have to buy 10 million things to do this. There is a process. There's a learning curve. We want to get your staff involved. We want them, I think about, Guy, when patients walk into a practice, we think as the doctor that they ask me all of the questions. We have to remember as the doctor that 9 out of 10 dentists that patients ask aren't asked of us. They are asked to our staff.
Right.
So we have to train our staff how to answer those questions.
Right. Absolutely. And again, that's why we exist. That's what we do all day long. Again, I know some more questions coming in. We'll answer them. Understand, certainly we're happy to answer these in more detail if need be. How much do we charge for an appliance? That's an open-ended question. And the answer is, in medical billing, we have to consider what you bill and then what you collect. And those aren't necessarily the same. And,
can I tell my story real quick, Guy?
Sure.
I'll let you finish. I'm sorry I interrupted.
No, that's fine. No, I was pretty much finished. I was just going to say that it's not the same. Most dental offices produce and collect the same. Their goal is to have 99% collections to production. And if you're doing medical billing well, and you're out of network in particular, you're going to have write-offs. You're going to have, yes. I'm having knee surgery a week from today. They called me today and they said, here's how much you're going to pay on Tuesday. The bill is going to be more than that. We'll figure it out after we see what your insurance company pays. And it's a friend of mine. It's somebody I know.
Significantly more than that.
Significantly more. So the answer is I can't really tell you. I can tell you that we get paid $0 on some cases because we do them for charity, or sometimes insurance doesn't cover what we think, and we get paid over $6,000 on some cases in my practice. And the good news is it works out to where it's a more profitable procedure than I used to do to do any of my dental procedures. So as far as how much money per hour of my time, it's a very profitable in most practices. So let's hear a story. I'm interested to hear it myself.
Well, the story, we did a lunch and learn for a cardiologist's office. So we take this really fancy barbecue stuff over there, and we're setting it all up, and this guy walks in. Everybody's got scrubs on the office, and man, I'm thinking this guy's the janitor, right? Because he walks in, he's piling all this, stuff on. This is a cardiologist, remember, office, and he goes, "How much you charge for these things?" And he's got a dental device, And I go, I'm sorry, I don't think we met. I'm Dr. Drake. He goes, "Oh, I'm Dr. Smith. I'm the cardiologist." Well, okay. Well, can I ask you a question? Yeah. How much do you charge for a heart cath? He goes, "Well, it depends." It depends on what? He goes, "It depends on their insurance. Everybody pays different things. That some people allow more, so we charge more. We do this and that." And I said, "Well, that's my answer too." And he looked at me and he shook my hand. He goes, "I think we're going to get along just fine." That was it. That's how much time I spent with that guy. Now, we did talk with the staff and stuff like that. This is a year ago. We just looked in the software the other day. You know how many patients he's referred me in a year? 42.
Wow.
So that lunch and learn turned into 42 dental devices that we made. So, again, that's part of that, Guy. I think that's hard for us as dentists to get through our mind is that, write-offs are just part of the norm in what we do. And a physician knows and understands. He kind of bills as much as he thinks he can, and then he has an allowed fee, an allowable fee, and then they write off part of that. So that's hard for us as dentists to get our hands wrapped around, but it's an important thing that we need to understand.
But I also mentioned you don't have to do that. If you're treating your patients in your office who are your patients of record, you have a fee-for-service office, you can do this as a fee-for-service procedure. You have certain forms you need to fill out, especially if they're Medicare, and saying that we're not going to be a provider here, and charge your patient. So we walk you through that. If you type in consultation and you decide to join us for the 3 months, we will walk you and your team through to make the appropriate decisions for your office. Because when someone says, how much do you charge? You know, what kind of car do you drive? Does that mean you're going to get the same car as me? No, I have different needs than you do. I have different overhead in my household, and I have different overhead in my office. And so I think the correct answer is we'll be happy to walk you through the options, how the various billing models work, and help you as a team. And I highly, highly encourage you to involve the team in this decision. Decide as a team how you're going to manage this. And then once you decide, then we'll help manage it for you or help you manage it. So again, we'll be happy to talk to you about that specific questions, or if you decide to do an introductory offer in 3 months' time, you're going to be treating patients and getting paid based on the system that is appropriate for you or your office and what you're comfortable with. We're not telling you you should do it the way I do it, the way Rich does it, because actually Rich and I don't do it exactly the same way. Everybody does this just a little bit different. But what you do have to do is have a plan. You can't be all over the board, charge one patient fee for service, this person this amount, that person that amount, and no one knows what's going on. That's a recipe for disaster. So,
well, you know what happens, Guy, is I'm the patient now, and when I see that you all don't really know what you're doing, you know, I'm conveying incompetence in that particular instance. So part of that's the fake it till you make it. If you just have a plan, you go, well, this is what we charge. Here's your out of pocket. Here's the paperwork. You sign it. This is what we do. We're going to bill your insurance more than that amount, but this is all you're responsible for. It's not any more complicated than that. So what I hope, one of the things that people have picked up on here, Guy, is how much the verbal skills that we talk about are important in how we manage this process, and we do that. You know, you got to have a system. You got to have a way to organize things and put things in slots and do all of this stuff. But that's part of what our member support expert team does as well, is to teach you those word tracks.
Yep. Well, it looks like we have, I think, Rich, is that all it looks like you all have done a fantastic job, because you're better typing than I am. I think are all the questions.
Mostly our team, yeah. I think we've covered pretty much everything. So we did pretty good on the time. Thank you, Guy, for putting that excellent PowerPoint together. As always,
sure.
Good job.
Well, we look forward to having you all on in April, or whatever the date that was. Back it up one slide, I think. 17th. Yep, the 17th. And try to come to one of our courses if you can. Whether you've been doing this, you're new to this, or you've been doing this for years, we get the same positive evaluations that this was worthwhile, because the people who are new learn a ton. Like, wow, this is eye-opening. The people who've been doing it a while go, wow, this is a much more efficient way of doing this to be more profitable and enjoyable in my practice. So either way, we hope to see you at one of those courses or back on this webinar. Thank you all for taking your Tuesday evening to spend with two old guys that talk about sleep. That's pretty impressive. We had that many people on here tonight. So, Rich, have a good night. And I owe Rich $1 from the game last night. I'll have to. I hope my credit's good with you, buddy.
All right, everybody, have a great evening. Thanks for spending time with us.
Bye-bye.